We have data on the QFR. The cutoff is 0.89. You find that the cumulative sometimes increase in the risk of vessel-oriented cardiac endpoints. Here again, it is possible to have a pullback trace to look for the reasons for the reduction in the functional achievement. You will find that again, the focal lesions are significant in such a situation, which will lead you to correct those and ultimately get a better post-PCI physiology. The important aspect of a pullback or pullback analysis is to get a complete idea of the longitudinal vessel analysis. And that is an additional or rather more important point than getting an absolute value at the end of the procedure. So this is an important aspect of post-PCI physiology. It can be done by the pressure wire, as I have told you, either FFR or non-hyperemic pressure ratios like IFR or RFR also is available to identify the residual focal lesions. When you find that there is no distinct focal rise, rather there is a slow pressure drift, it indicates that diffuse disease. And there is no point in placing a stent for diffuse disease. You better treat the patients with medications. Now we can combine with imaging in these situations when you pull back, because you wanted to have more idea about the focal lesions, where exactly, either like stent under expansion or malapposition, plaque protrusion, thrombus within the stent, edge dissections, incorrect stent. All these could be made out by an intravascular ultrasound or OCT when combined with this functional assessment. Now, in that particular case of LED, we found that it was 0.77. The RFR was 0.91. But we thought of doing the PCI. PCI was done. And as I told you that the FFR remained to be 0.79. What is the pullback? You'll find that pullback shows a FFR gradient inside the stent of 0.79 to 0.88. And a stent boosting, I didn't do the imaging also, but stent boosting quickly showed that there is an under expansion in the proximal to mid portion of that stent. And then it was optimized and then repeated. And you find that the PDP is 0.96 and the post-PCI RFR is 0.97. These are excellent values. And the result, this is unlikely to have an event or rather very, very low event rate. Now, this is another case, an LED lesion and a circ lesion. Circ lesion is tighter, more than 90% stenosis, so that has to be stented, no requirement of physiology. LED look, the RFR is 0.88, less than 0.89. FFR is 0.7, so certainly ischemic. PCA has to be done, PCA has been done. And then the pullback, post-PCA pullback, RFR is 0.93, and FFR is 0.87. Okay, this is okay, but we found that 0.90 is cut off for the FFR, so it is suboptimal, you can call. And RFR is again the optimal value is, although 0.89 is the ischemic optimal value, they put as 0.95 from the defined PCA trial. And then the pullback here really shows that the gradient is actually outside the stent, distal to stent. It is a slow separation of the curves showing that there is only a slow difference in the pressure. And therefore, that is not to be treated. And we found that was because of some diffuse disease by IVUS. But the stent was excellent. MSA 9.46, 8.71. So it is quite acceptable. So you can combine physiology also to substantiate or enhance the post-PCI physiology. Now, there is recent studies of using intravascular ultrasound to a post-PCI pullback physiology and found that although that adoption has not resulted in a significant event reduction, it was shown that when you combine imaging, the chances of doing procedures to optimize has definitely increased. Probably it will contribute to better result of the procedure. Now, another interesting thing which has developed in physiology is simulation of PCI before actual PCI. We have this methodology available with IFR, QFR, and CTFFR also. In IFR, you have that angio-co-registration and syncvision software adoption. You will find that you can have the IFR gradient in the circumflex lesion. The length of the lesion can be made out. And the virtual stenting showed that the 0.83, which was the first pre-procedure, the first IFR, has been corrected to 1. So what we are going to do is going to have a good result at the end of the procedure. So this virtual PCI has been validated, and the IFR gradient registry showed that the pre-procedural value and the post-procedural value agree in a large proportion of cases. So this may also contribute to have a better idea of what you are going to get at the end of the procedure, so you can have modification of the procedure done before the actual PCA itself. Now, do we have really clinical data to support that this sort of approach is really beneficial in clinical practice? We have data for the FFR in a group of patients, and when they found that the optimization has been done, the post-PCA FFR has been shifted or increased from 0.78 to 0.87. This is significant improvement. And that 0.87 is associated with reduction in death, the upper panel, and 0.85 is associated with reduction in TVR. Now, defined PCI, again, I told you that the IFR cutoff is 0.95, and it has been shown that after 1 year results by Patel has shown that the cardiac death, MI and TAVR, and cardiac death and MI hard endpoints all are reduced when you achieve a post-PCI IFR of 0.95 or more than 0.95. Target FFR is again a similar trial based on the FFR pullback, and again it was not a very positive trial, but again showed that FFR guided optimization strategy at least reduces the number of lesions with less than 0.80, or suboptimal PCI post-PCI physiology could be reduced by these optimizations. And defined GPS study we are looking forward to, because we don't have a randomized control trial of a large number. This is a randomized control trial where the physiology evaluation versus angiographic evaluation, and the trial is ongoing. We'll get that right. So I would summarize that suboptimal post-PCA physiology is quite common. We have to look for that. It is independently associated with future risk of MACE. However, the predictive value is modest. Longitudinal vessel analysis helps to identify the mechanism of low post-PCA physiological value. It's not the one number or 1 point. You have to do a pullback, or a vessel analysis has to be done. And the clinical benefits of physiology-guided PCA optimization has been demonstrated in various trials, but we do want a large randomized trial, which one is looking forward to. And pre-PCA information from the so-called simulated PCA may help us to have a better strategy for getting a good post-PCA physiology. Thank you very much for your patient listening. Thank you.
Thank you, Dr. Bahuleyan. Very fantastic talk. I think this is something that we are looking forward for, and more data to come out.
Right.
And I think everyone should follow the typical steps of pre-dilation, stenting, post-dilation, appropriate size, about 0.25 or 0.5 millimeters more than the stent that has been used, and then perform FFR or IFR and see what value that we get. I think this is an area where a lot of research is ongoing right now. Any comments, Dr. George?
Yeah, I think, optimization of PCI using IVUS, OCT and FFR is the thing which we have to start practicing more and more, because the outcomes do change. And we have seen that from the ultimate trial. And now, with the FFR also, we are expecting to have similar outcomes. The only thing is that sometimes in those complex situations, even putting a FFR wire upfront is also a very good idea. In situations where there are multiple lesions, you pre-dilate, you keep knowing the FFR at all stages, or the RFR, basically. So instantaneous, these values are very useful, and then final pullback run is, to be done in these patients.
Yeah.
And many times we have to do optimization if the FFR wire is there. So that is something, which we have learned over a period of time.
Can we calculate residual functional syntax in multivessel, multisegmental PCI? Residual syntax less than 8.
Residual syntax score.
Residual functional syntax.
Yeah.
Function.
Residual functional syntax has not been validated the way in which I have told. In fact, even higher syntax score patients, as shown up in I think a FAME-3 trial, they have shown that the usage of physiology has been useful to get a better post-PCI physiological values. Yeah. So as Praveen has pointed out, I will also agree that in certain situations of bifurcation lesions, you can keep the wire ahead and try to find out what is happening to the side branch, and then complete the procedure if the side branch physiology is negative.
Yeah, and also, now increasingly with the QFR software.
Yes,
I am not practicing that right now. Maybe Ramesh or Dr. Shiban, are you practicing the, pre and post QFR, and because then you don't have to put a wire also.
Yeah, we are just doing with FFR CT right now, but we're getting cath works and medicine to evaluation into our hospital.
I think post PCI FFR is more well established in LAD lesions actually.
Yes.
Still circumflex RCA data is lacking.
Yes.
Yeah,
Professor
we are
Bahuleyan.
practicing that, but not routinely. Not routinely. When we have the suspect that there is some problem, of course we'll use FFR. Yeah.
Dr. Manoj.
Yeah, Professor Bahuleyan, fantastic talk
Yeah.
to listen and to upgrade our knowledge in this current scenario.
You are
My
not
question
audible,
is-
Manoj. Little louder.
Please speak loudly, Doctor.
Yeah, my question is, when we optimize the PCI outcome with a stent, with all the parameters by the image guided, even after the image guided optimization, would you still consider a physiology-based assessment in that situation?
Well, I think that is again an area which is not we can't give a definite answer for that. I told you that we have post-PCA physiology done by the pullback tracings and the FFR react. And then on to that, the IVUS analysis has been done. And they found that in the case of IVUS usage in that particular situation, number of times you have to optimize. Say, for example, choose a higher sized balloon or a higher sized pressure or an additional stent. These procedures were more when we used to having IVUS. So I think that is an area which is to be investigated. Whether the post-PCI physiological guidance versus an image guidance or a combination. I think that is the next stage of the ongoing.
One short final question by Dr. Anil
I think
Dao.
we should not forget that FFR is a continuous variable. And we should not run away from the fact that we recognize this. When the defined PCI results came, we were all alarmed that 25% of what we have done is inadequate. But truly, we can define it better. And if you have a defined PCI-like result, then you probably do imaging and decide what you can do. If it is focal, you can relieve it. If it is diffuse, you have to leave it and rely on medical management.
I think that is what is Alan Jeremias is
Yeah.
more forceful, and he is pursuing to get a 0.95 in each and every case so that the human rate will be practically nil. That's what we'll get the results soon.
Yeah.